Hello, everybody. Thank you for waiting. And we had some technical difficulties, but we're about to start. And Dr. Adereti's grand rounds today. Dr. Agarwal is going to present or introduce IJ.
Hi, everybody. Today, I have the honor of introducing Dr. Iyanujesu Adereti, aka IJ. She's a PGY3 resident at University of Louisville. Dr. Adereti's career began in Nigeria, where she earned her medical degree from Obafemi Awolowo University. She then worked as a general practitioner in various hospitals in Nigeria before relocating to United States. Prior to starting her residency, she worked as a psychometric rater on several psychiatric research projects. She has launched her online focus educating programs in Nigeria as well. During her residency training, she was awarded Outstanding Resident Award in Consultation and Liaison Psychiatry. She served as a vice president of the Residency Association Committee as well. Dr. Adereti's clinical interests are centered around adolescent mental health, and she has presented research on topics such as substance use as well as suicidal behavior in this population. She's dedicated to education, actively teaching and mentoring medical students during her clinical rotations. She's passionate about advancing her career, so she's going to be joining Child and Adolescent Psychiatry Fellowship at Emory University. Her topic is really fascinating, interesting, and I think very relevant to our day-to-day clinical practice. So there you go, Dr. IJ. Go ahead and start. Welcome.
Thank you so much. Thank you so much, Dr. Agaro, for the introduction. So I'm going to be talking about culture and psychopathology, how cultural context shapes the expression of mental illness. I don't have any disclosures or conflict of interest. And the objectives for this presentation, first is to help us understand the role of culture in mental health. And then we're going to examine cultural influences on diagnosis and treatment of mental illness, and also how we can apply cultural competence in our clinical practices. While I was in second year, I managed a patient. She is a 32-year-old female that migrated to the US from Cote d'Ivoire. And at the time that she came into the hospital, she was admitted for hyponatremia. She was about 33 weeks pregnant and developed hyperemesis gravidarum. And this was how she became hyponatremic. She was admitted to the ICU, and then psychiatry was consulted because they felt that she was exhibiting some symptoms of psychosis. She was refusing care. She was not eating. At some point, there was talk of getting an MRW to get a court order to pass an NG tube to help her eat. And at that point, I was actually not on the consult service, and then the attending called me, said that I heard that this patient is from Nigeria. Do you happen to speak the same language that she speaks? Because I feel that we are missing something with this patient. And so I went to speak to this patient. Luckily, she spoke one of the over 300 Nigerian languages, the same one that I speak. And after talking to her, I discovered that she was delirious at some point. At the time I was talking to her, she was no longer delirious. She grew up in Nigeria, moved to Cote d'Ivoire around 7. And so she spoke some English and also spoke French, because French is the official language in Cote d'Ivoire, English is the official language in Nigeria. However, our primary language is the Nigerian language that she spoke. I discovered that because of when she was delirious and at now, she was having trouble understanding what was expected of her. And so she developed some distrust with the healthcare providers. And because of that, she felt like they just come and they just jab me. And that's why I keep saying no. And then she wasn't eating because she was pregnant and did not like the hospital food. And so after talking with her husband, we were able to get some food for her. We were able to explain the process. And within 48 hours, she went from thinking of getting an MRW to actually being discharged from the hospital. And so this kind of, brings to the forefront the importance of culture when we are taking care of our patients. And culture is defined as a set of beliefs, values, practices, and norms that characterize a group or society. It shapes our perception, behaviors, and ways of interacting with other people. And culture can be a source of strength. It can also be a source of distress. And talking about cultural psychiatry specifically, it operates under a framework that culture is learned, it's propagated, and it's constantly changing. And it affects how individuals understand mental health and behaviors, and also how mental health professionals, how we provide services. It's not just talking about like racial difference or ethnic difference. It's also how we as clinicians perceive things. And this is a product of our ethnocultural backgrounds, our professional training, and also the context in which we are working. I'm going to talk about the history and evolution of cultural psychiatry. This is a relatively young field, but it has had a lot of iterations over the years. First, in the pre-19th century, before psychiatry was formally established as a field, mental illness was often interpreted through religious, moral, and supernatural framework. And then we had the era of colonialism, the beginning of that. At that time, the Western culture kind of began to impose European views on mental illness in the colonized population. And a lot of times, indigenous practices were either pathologized or seen as hindrances for treating mental illness. And then in the 19th century, there was this thought of universality of mental illness. So it was thought that mental illness was the same everywhere. However, we had like anthropology, we had scholars like Emily Durkheim and Sigmund Freud that started talking about the role that that culture plays in shaping individual behavior. Next, in the early 20th century, that was when cultural psychiatry began to emerge as a field. At that time, there was this growing recognition that the idea of universality of mental illness was probably not very correct. And one of the things that shaped this was also colonialism, because of colonialism, there was a lot of globalization. And so people started to question the universality of mental illness. And then following World War II, cultural psychiatry began to gain more formal recognitions in the US and in Europe due to migration and multiculturalism. And during this time, global organizations like World Health Organizations, they became more involved in cultural psychiatry, recognizing the importance of this. And even during this time, ICD-10 began to include cultural considerations for classifying mental illness. And at this time also, ethnopsychiatry started emerging, which focused on the different cultural groups, how they conceptualize and treat mental illness. And then in the late 20th century, we started talking about things like cultural competence, language barriers, trauma, cultural displacement, and the effect that all of this has on mental health. We started talking about social determinants of mental health as a whole. And that brings us to the 21st century now. In the field of cultural psychiatry is like a recognized field in psychiatry. And we're talking about things like cultural neurobiology, which is researching how culture influences brain development and psychiatric disorders. We're talking of, trying to make sure that we decolonize psychiatry, challenging Western-centric mental health frames, and trying to integrate indigenous and non-Western healing practices into the field of psychiatry. So still talking of the history, I'll just talk about some figures that have played an important role in the field of cultural psychiatry. This is Dr. Arthur Kleinman, who is credited for modern cultural psychiatry. He developed a concept called the concept of explanatory model of illness, which is a framework to understand how individuals perceive and make sense of their illnesses, including their beliefs about what causes their symptoms and what kind of treatment they feel they need. And next is Dr. Frantz Fanon. He was a psychiatrist and a post-colonial theorist. What he did a lot of work to explore the psychological impact of colonialism on not just the colonized, but also the colonizer. And so he connected racial and cultural oppression with mental disorders, framing psychiatric illness as not just one person's experience, but also a collective social and political phenomenon. So how does the DSM-5 approach cultural psychiatry? The DSM-3 that came out in 1980 had some criticism. They felt it was very Eurocentric. And so the DSM-5 made one significant update in its approach to what is called cultural concept of distress. And so they kind of tried to acknowledge the important role that culture plays when shaping our experiences as individuals. And they organized this concept into three main categories. The first category is what is known as cultural syndrome. This is also known as culture bound syndrome. And this refers to patterns of symptoms or behaviors that are recognized as illness or dysfunction within a specific cultural group. So these syndromes, they often align with diagnostic categories, but they are culturally specific expressions of distress. I'm going to give us some examples later on in the presentation. The next category under this concept of distress is cultural idioms of distress. And so in 1981, someone called Mark Lucetta introduced this concept, and it refers to ways in which people in a particular culture refer to their suffering. So it might not really be, they might use terms that we know already, but in that particular culture, it means different things. So for example, let's take the word heartbroken. When we think of heartbroken, you think of maybe somebody lost a romantic relationship. However, in some culture, it might mean like loss of a family members. It might mean something entirely different. Another example of a cultural idiom of distress is the word nervous. So nervous translates to nervous. And however, in some culture, it doesn't necessarily mean anxiety disorder, like we kind of think of. It might just be a different way of expressing emotional distress and tension. Now, these are cultural idioms of distress. They not only help the people within that culture express their emotions, it can also be protective. So an example, in Mexico, there's these Osaka caregivers that take care of elderly population. And so in this elderly population, they tend not to use words like dementia or Alzheimer's, because when they use words like that, it's almost like you're stripping those people of their dignity and stripping them of their place in the society. And so they use terms like, oh, this person is just suffering from some forgetfulness, to just help them protect their dignity. The third concept is called cultural themes. So cultural themes essentially refers to underlying cultural beliefs and values that influence how people perceive and experience mental health. So this actually shapes how people interpret what is causing their distress, and also shapes how they respond to it. And so some cultures, mental illness may be seen as maybe some form of spiritual imbalance, or they might see it as some form of punishment. And so DSM-5 recognizes that these things contribute to coping strategies and help-seeking behaviors. And it's important for us as clinicians to be aware of this when we are dealing with patients from a different culture than us. So I'm going to be talking about how culture shapes some of the common psychopathologies that we deal with. So first, I'll just give us some examples of cultural syndrome, which we have defined before. The first one that I'll talk about is the Taijin Kaifusho. So Taijin Kaifusho is a Japanese word, and it translates to the disorder of fear. It's a Japanese form of social phobia anxiety disorder. And to understand this disorder, one needs to have some understanding of Japanese culture. In Japanese culture, they stress the good of the group over individual desire. And so someone with this syndrome has this phobia that their body appearance or the way their body is functioning is very offensive or displeasing to people in their community. And so this is extremely distressing for somebody who feels like the way my body looks is throwing off the group dynamic, is making other people uncomfortable. And so that is a type of anxiety disorder that is specific to the Japanese culture. Another cultural syndrome is ataque de nervios. Ataque de nervios is also called Puerto syndrome, and it's a culturally bound psychological disorder that is similar to panic attack. This is usually seen in Latino cultures, and it's referred to as acute distress with somatic symptom. It's somewhat similar to panic attack, but there are some symptoms that is a little bit different. So for example, they have this intense fear and an inability to move. They have uncontrollable screaming or crying. They might have fainting or seizures. They might have like verbal attacks and become physically aggressive. Unlike a panic attack, in ataque de nervios, the anxiety and fear is considered normal and healthy responses to the occurrence of this syndrome. And this is a picture that is showing someone with facial tics. So this might be one of the somatic symptoms that somebody that is dealing with this syndrome might experience. So how does culture shape mood disorders? For this, I would be comparing Western and non-Western culture. And I want to preface by saying that not one of this culture is superior to the other. This is just for educational purpose to help us. When it comes to depression, it was previously thought that non-Western communities, depression presents more in form of somatization. However, Dr. Lawrence Kamaya, who is a leading cultural psychiatrist from Canada, he did various studies, and he says that this is not entirely true. He says that the rate of somatization with depression is about the same in both Western and non-Western cultures. He argues that the reason why it seems more in non-Western cultures is because the patients that were studied were seen by primary care doctors and traditional healers. Whereas in Western culture, the patients that were studied were seen by psychiatrists, hence the discrepancy. And so essentially our culture dictates how we express emotions. And still talking of depression, if we compare, say, China and the United States has a lifetime prevalence of depression that is about 16% to 25%, whereas in China, it's about 6% to 7%. But this doesn't really mean that the people in China are happier than the people in the US. March 20 was International Day of Happiness, and there was a rating for happiness rating globally that was released. The US was number 24, and China was number 68. And since around 2012, when they've been releasing the rating of happiness, the US has always rated higher than China, even though the rate of depressive disorder is higher in the United States than in China. And just before I go on, this scale is the Cantrell ladder, which is where the happiness rating scale was derived from. It scores from 1 to 10, 10 being your best possible life and 1 being the worst possible. And so the question arises, why is there a discrepancy in subjective feeling of happiness and depressive disorders between the West and the East? At first, it was thought to be due to underreporting. So they felt maybe the people in China were underreporting their depressive disorders. However, if you take the prevalence of schizophrenia in both countries, it's very similar, despite the fact that schizophrenia is stigmatized in both cultures. And then different studies were done. Dr. Lawrence Kaman wrote about this, and also psychologist June DeVore. They all discovered that the difference comes from how both cultures view emotion, especially negative emotion. So it's thought of that we in the West, we tend to divide the world into good versus evil, happiness versus sadness, that we kind of tend to mentally isolate people, objects, and events from the broader context in which they occur. Whereas in the East, they kind of have a more holistic view of the world. They actually expect opposites to coexist. So you hear things like yin and yang, or a spot of light in the darkness. And what this leads to is that negative experiences for the Easterner is not all consuming, because the fact that I'm sad does not mean I cannot be happy at the same time. Another thing that happens with emotions is that Westerners, we tend to think of emotions as arising from a stable self. So if I think of myself as a happy person, then I need to discount any negative experiences as anomalies, not part of who I am. Whereas Easterners, they see themselves as their emotions as constantly changing. And when you feel like your emotion is constantly changing, then negative experiences are less threatening, because you're like, this is not a permanent thing. This is something that is going to change. Something else that was looked at was behaviors that we engage in when we have negative emotions. So two of those behaviors is suppression and rumination. So both Westerners and Easterners suppress emotion and also ruminate. However, when Easterners, when they suppress their emotion, they tend to do that so that they don't affect other people. And so they will go along with activities, even though they are suppressing their emotions. And we know from CBT that our behavior changes our emotions. And so because they are, going along with things, even though they might have this subjective feeling of sadness, they don't end up developing a meeting criteria for a full clinical depressive episode. The same thing with rumination. Instead of that, Westerners, when we think of negative emotions, we think of things like, oh, what's wrong with me? Whereas somebody in the East will think of what is wrong with this situation. So whereas rumination might lead someone in the West to have like this negative thought cycle about themselves, someone in the East, it might lead them to actually problem solve. And so essentially, the worldviews, while it might be protective for, like in the East, for emotional disorder, it reduces overall level of happiness and satisfaction with life. Next, I'll talk about how culture shapes suicide rates and risk factors. For this, there has been studies, and this particular one was done by Chu et al. In 2010, and they developed a cultural theory and model of suicide. But before talking about that, we know that we've all been taught that the risk of suicide for a white male is higher than for a Black female, for example. However, if you look internationally, these gender values don't hold true. For example, in Latin America, the young Latina women are 2 times more likely to attempt suicide than the average population. So this tells us that culture has some factor in this suicide rate. So the cultural model of suicide there were 4 factors that they found that were kind of responsible for 95% of cultural risk factors when it comes to suicide. The first one is cultural sanctions. So cultural sanctions refers to how a society either supports or condemns suicide based on its cultural norms, values, and ethical belief. And so you're thinking of the level of acceptance or prohibition of suicide within a society, and this will influence how people perceive suicide, how they understand it. So it's almost like this kind of influences the who, when, how, and where suicide occurs in different cultures. So an example is something called altruistic suicide. So there are some cultures, suicide may be seen as honorable or self-sacrificial act. So an example would be gang members that want to attempt suicide by cops, because to them, that is like a more honorable way to end their life than them doing something to themselves. Or some cultures that might see suicide as a way to protect their family, to protect their group, or to protect their country as a whole. And then there's also something called egotistic suicide, where individuals, they feel isolated, disconnected, or insignificant within their community. And this kind of suicide is more common in individualistic society, where person's autonomy is emphasized. The next factor that was in the model of suicide is cultural idioms of suicide. Cultural idioms of suicide is very similar to the idioms of distress that we already talked about. Is essentially how different groups express thoughts of suicide. So some groups might not say things like, I'm having thoughts of wanting to hurt myself. They might say, for example, I'm having a heavy heart, or I feel like I'm getting lost. And so it's important that when we're talking to people from different culture, we are asking them exactly what it means by what they're saying, because they might be speaking in some sort of idiom that is just particular for their culture. Next is minority stress is a factor that has been a cultural factor that is a risk for suicide. Minority stress refers to unique experiences unique stress experiences by individuals that belong to a marginalized or minority culture within a larger society. So it can include like ethnic minorities, sexual minorities, immigrant population. Under minority stress, there's something called identity struggle. And so for people that come from a different culture to another culture, where their culture is not the predominant one, they can arise like a conflict in them. So for example, you think of like a 19-year-old Latina girl that migrated from Cuba to the US. The US has more like by the age of 19, most kids in the US are given more independence. Whereas this person that is coming, the parents don't understand that. They're like, no, you really shouldn't have this independence. But they see their friends having this, and then there's a conflict in them. And this can be a risk for suicide. And then the fourth risk that was talked about in this model is social discord. Social discord refers to the breakdown of social cohesion or harmony within a community or a society. So this could be political unrest, economic instability, rapid cultural change, and other factors that disrupt the social fabric. And so all of these things are things that are kind of like for whatever, when you're seeing a patient from a different culture, they're things that we kind of should think about and ask about to assess their suicide risk. So Chu et al., from their work on the model of suicide, they developed a questionnaire called CAS, which is the Cultural Assessment for Risk of Suicide. The original one was about 39 questions, but this is the shortened version of this. So there are 14 questions. It's self-administered. There are numbers underneath each of the boxes. You tell the patient to ignore the numbers, and then you ask them to answer the questions. Question 12 to 14, not everyone answers it, because question 12 talks about someone who was migrated to a different culture, and 13 and 14 is about people that might be gender or sexual minority. And based on their score, for example, if the person answers for question 1 to 11, a score that is greater than 38.5 shows that you need to do a further suicide risk assessment for this person. Now, how does cultures shape psychosis? First is, how do different cultures interpret psychosis or schizophrenia? In Western culture, we tend to see psychosis that from like a medical or biological point of view. We think of it as stemming from this. We focus on medication, sometimes hospitalization, psychosocial support. However, in non-Western cultures, some cultures tend to see psychosis as religious or spiritual beliefs, especially when it comes to hallucinations and delusions. So something that we in the West might think this is a delusion might actually be this converted spiritual experience in another culture. Or it can actually be something that other people are actually they're actually wanting to experience. So I studied in Nigeria, and when delusions was being defined to us, it was defined in cultural concepts. Nigeria is a very religious country, and so it's very normal to have spiritual leaders on TV saying things like, oh, God just told me this. I just heard God audibly tell me. And so they would tell us like, well, we're not going to say these people are psychotic because our culture agrees that this is an experience that some people have. Another thing when it comes to how cultures see psychosis is there are studies that were done in Nigeria, Trinidad, and even India that in these cultures, they view decline in function, disruptive behavior, and wandering as the symptoms for psychosis that they actually treat. They don't really view things like distortion in perception and beliefs. They don't really emphasize that as much as we do here in the West. Another difference is in treatment approaches. So universally, antipsychotic and psychosocial treatment is the treatment for psychosis, especially schizophrenia, all over the world. However, based on different countries, one, the choice of antipsychotic differs. So for example, in China, 1/3 of patients with schizophrenia are prescribed clozapine. And that's because it's more affordable and they feel that it's more effective. Also, in China, they have like alternative treatments where, for example, is something called the China's Wendan decoction. This is like a mix of herbs that are used to treat mental illness, and they've actually studied them, and in the short term, they've proven somewhat effective on their own for schizophrenia, and when combined with antipsychotics, they've actually had some positive outcome. In a lot of non-Western countries, people do a mix of medical management and then their own traditional thing for psychosis. And even when we are seeing these patients here in the West, we need to ask them if they are taking any other thing, from their culture that they're using for their treatment. And now another thing I wanted to talk about is stigma and psychosis. So psychosis is stigmatized in almost every part of the world. Here in the West, it could lead to like social isolation, it could lead to unemployment and poor social integration. In non-Western countries, psychosis is also stigmatized. However, a lot of family and community support is still usually present for these patients. And for example, in my country, people will tend to ensure that nobody knows that they have somebody psychotic in their family. And so they're doing a lot of support for this person. This reason is because if I want to marry from a particular family, people will do research for like 3 generations to be sure that nobody has ever been psychotic. And if somebody has been psychotic in that family, then it's going to be like a long hill battle to convince your family that you want to marry into that family. And so because of that, people tend to like protect people who are psychotic to make sure that nobody knows about it in such a way and kind of give them as much support as possible. Finally, for psychosis, let's talk about the cause and prognosis of schizophrenia in Western and non-Western countries. So a lot of studies have been done on it. WHO did a 10-country study, and then Jablonski et al. Did a study of industrialized versus underdeveloped country. And then they found out something that is called the paradox of developing nation. And this paradox is that in developing countries, they tend to have better prognosis with schizophrenia. They have like better longer time outcome, lower relapse rates, and better social integration. And this is thought to be maybe due to strong family support and community support. Now, how does culture influence how we diagnose and treat mental illness? First, I'll just talk about health-seeking behaviors, because if the patients don't come to us in the first place, we can diagnose or treat them. There are so many cultural factors that influence whether someone will seek mental health help with a medical professional. So first is, we've talked about stigma, not wanting anybody to know what is happening, thinking people are going to say like you're crazy. Another thing is medical versus spiritual explanations. What people think is the cause. When you think something is, what you think is the cause of your problem will influence how you go about getting a solution for it. And so in cultures that interpret mental illness as possibly a spiritual attack or a possession of demons, they tend to seek help with spiritual leaders. Another thing that could be a barrier to seeking help for mental illness is a mistrust of Western medicine. Historically, the African American population, they kind of have some distrust for medical professionals, given their history. Another barrier would be language and communication barrier. The story I told at the beginning, the main barrier was communication with this patient. It was difficult for her to understand what we were saying. It was difficult for us to understand her, and for some reason that got interpreted as psychosis and paranoia. A lot of cultures turn to herbal medicine, faith healing, and shamans when it comes to mental illness. And our role as clinicians is to not invalidate those things, but figure out a way that we can merge both together to get the best outcome for our patient. Talking of treatment, I think no talk about treatment when it comes to culture is complete without talking about ethnopsychopharmacology. Ethnopsychopharmacology is a concept that calls attention to the variability in psychiatric medication responses from influence of biological factors like genetics, and then non-biological factors like race, ethnicity, cultural influences, and experience. So first, we need to remember that a lot of trials for psychotropic medications, historically, they were done in North America and Western Europe. Up until about 10 years ago, when there are some guidelines about diverse population in clinical trials. And so because of that, the information on ethnopsychopharmacology is really not as good as it should be due to that limitation. However, we do have some data that suggests that biological ancestry plays some role in how we respond to medication. In the 1970s, there were reports that says that people from China required lower doses of TCS than white people in Australia. And if we take carbamazepine as an example, on the prescriber information of carbamazepine, it says that this medication, the effect of race and gender on the pharmacokinetics have not been systematically evaluated. However, if you look at Lexapro, on Lexapro, it says that there was no difference in the pharmacokinetics for race and gender. And so that means there are some studies that has actually shown this. And specifically for carbamazepine, there is a warning about Steven-Johnson's and 10 that it's 10 times likely to occur in people that have an inherited allelic variant of human leukocyte antigen B. And studies have shown that this is found almost exclusively in patients with ancestry across broad areas of Asia. And so this is a table that of a study that was done in North America and Asia to see the percentage of people that shows these variant allele. And if you see here, in North America, Asia had the highest percentage. And then in Asia, Han Chinese and people from Singapore had the highest percentage of this. Another thing that I wanted to talk about in ethnopsychopharmacology is cytochrome P450. Dr. Patel, did an excellent talk on pharmacogenetics, and he told us about inducers and rapid metabolizers and intermediate metabolizers and poor metabolizers. So Sumishi et al., they did a study that shows that 29% of Ethiopian population, they had duplicated active genes for cytochrome P2D6 compared to 15% of Arabs and 1 to 2% of Black, Asian, or European population. In contrast, 7.7% of Caucasians are poor metabolizers due to mutant alleles of cytochrome P2D6. And so while we usually don't let pharmacogenetics drive our treatment of patients, this is still something to keep in mind when we are treating a patient and they are not responding as we expect them to respond. In 2022, TM Pharmacopsychiatry Journal, they published a guideline on dosing consideration for clozapine, and they did suggest that it should include ancestry, sex, and presence or absence of metabolic, presence of inducers or inhibitors. So these guidelines, they did a study in so many different countries using ancestry. And in this guideline, they did recommend a more conservative dose titration for patients of Asian ancestry and a higher dosing for clozapine for people of African ancestry. And they did this by checking clozapine levels in these patients. And when they gave them like 300 milligram dose of clozapine, and they found out that for people of African ancestry to get to the therapeutic level, they needed to be at least 300 milligrams. For a European, they needed to be on at least 220 milligrams of clozapine, and for people of East Asian ancestry, they needed to be, it was at 112 milligrams of clozapine for them to get to a therapeutic value of 350 nanogram per ml. The last thing when talking of how culture could affect medication is diet. Every culture has different diets, and we do know that some food could induce cytochrome P450, and also some food could inhibit it. So for example, you have some spices like for example, cardamom and black pepper, they are cytochrome P450 inhibitors, whereas food like cauliflower, cabbage are cytochrome P450 enzyme inducers. So for the last part of this talk, I'm going to be talking about something called cultural formulation interviews. The DSM-5, they had a cross-cultural issues subgroup. And this subgroup, they recognized 5 specific situations in which cultural factor will be extremely important for evaluation. Because I know we have like 20, 30 minutes to evaluate patients. And so it's not feasible to try to do a complete cultural formulation for every single patient we see. And so they recognized 5 specific situations. The first one is if there may be difficulty in diagnostic assessment owing to significant difference in cultural, religious, or socioeconomic background between the clinician and the patient that you are seeing. A second situation is if there is some uncertainty about the fit between culturally distinctive symptoms and diagnostic criteria. So maybe you're not sure, there's some uncertainty between diagnostic criteria and any of the patient's symptoms, not just one that either ourselves as the clinician or the patient think is culturally specific. Third scenario is if there's difficulty in judging the severity of the illness or the impairment of the illness. So for example, if somebody is describing a distortion in thought that you're not sure if it's a delusion or is a strongly held view in that person's community. And so you want to do a more thorough cultural formulation for that kind of patient. Fourth case is if there is this disagreement between the patient and the psychiatrist on the course of care. So if you don't, like the patient is like, no, this is what I think I need. But you as a clinician, you think, no, I don't think this is what this person needs. That might be a time to delve deeper into the culture of that person and why this disagreement is coming on. And finally, if you think there might be limited engagement in treatment and also adherence to treatment by the patient, doing a cultural formulation might actually help assess why that is happening. And so in order to do this, this DSM-5 cross-cultural issues subgroup, they put together a set of interviews called the cultural formulation interviews. These interviews were designed as a systematic cultural assessment method. They did extensive literature review and came up with 4 topics that needs to be covered in any cultural formulation. And based on this, they developed some questionnaires. The first questionnaire is the CFI, which is the cultural formulation, the core cultural formulation interview, the one you administer to the patient. And then there's the ICFI. The ICFI is the informant cultural formulation interview, which you might need to administer to family or friends to help understand the pathology that this patient is dealing with. And then they have 12 supplementary modules, which are just like explanations of the other two questionnaires. So on my left, I have the major topics, the 4 topics actually from which they generated the questions. Now, the CFI, the core one, is about 16 questions. And so it might be difficult to do this in clinical setting. However, understanding what they're trying to achieve with these questions might just help us so that we have a knowledge of it and be able to use this for our patient. So the first one is cultural definition of the problem. So it has questions like, if you were describing this problem to somebody in your family or somebody in your friend, how will you describe it? So just to help understand how this person views this disease in context of their culture. The second topic is cultural perception of cause, context, and support. So you want to explore how the patient perceives the causes of their distress, including cultural factors that might influence stressors and available support. So you want to ask questions like, so what do you think is causing these feelings that you are having? Are there certain, situations in your environment that has made these things more difficult for you recently? And then the third topic is cultural factors that has affected coping and past health-seeking behavior. So you want to ask them, in the past, that something like this happened, and who did you go to for help? What helped you cope those times? Because you want to know if there's someone that have this distrust for medical treatment, and that will give us an idea of that. And lastly, sorry about that. Lastly is cultural factors affecting the clinician-patient relationship. So you want to explore cultural barriers that or cultural facilitators that might actually influence the relationship that you're building with this patient. Because these are things that will affect adherence to treatment down the line. So this is just a snapshot of what the cultural formulation interview looks like. This is the questions that you have for the first topic that it covers, cultural definition of the problem. On my left is just like instructions for the interviewer, just for guiding the interview, and on my right is the questions itself. And so in conclusion, culture is always evolving. And because culture is always evolving, I believe the field of cultural psychiatry is also going to continue to evolve. It's an exciting and a transformative one. It's driven by a growing recognition that mental health is deeply intertwined with culture, social, and historical context. And while there are so many different variations in how people present various psychopathologies based on their culture, the CFI attempts to help standardize this in such a way that whatever culture this person you're seeing is coming from, it can help you gain a better understanding. And as globalization, migration, and technological advancement continue to shape society, cultural psychiatry will evolve to provide a more inclusive, culturally sensitive, and personalized mental health care. And this will not only improve mental health outcomes, but it will also foster a more equitable mental health system that acknowledges and respects cultural differences. Before I end my presentation, I just want to take this opportunity to thank some people. First, Dr. Agarwal, thank you. She's been my supervisor on my 3rd year, and thank you for all your help for my presentation. I really appreciate it, and your guidance this year. I also want to thank like the faculty, social workers, nurses. Where my first year of residency was really tough for me, and everyone was really so helpful. Like I'm just gonna name some people. Dr. Megan Pennell, thank you so much for just all your help. Dr. Swing, you were so helpful. And then just I think this is like most importantly, the PGY3 resident. I would like to name you all by name, but you were awesome. You know, when I was just reading about minority distress, I came from a different culture, and then I had this you know, this extremely traumatic experience happened. But because of you guys, I don't think I experienced any minority distress. You guys are amazing humans, and I am so glad that I got to work with you all. So thank you very much, and I'll take any questions.
Thank you so much, Dr. Adereti. For the virtual audience, we're going to start taking questions from the in-person attendance first, and then we'll move on to the virtual audience.
Thank you. Wonderful talk. You mentioned being from a different culture, not originally from the United States. The DSM is a product of the American Psychiatric Association and primarily American psychiatrists. So the perspective that's being presented, even when it attempts to be more global and more culturally aware, is an American perspective. What disorders that we commonly treat in the United States might be viewed as culture-bound syndromes by people from cultures outside the United States? Things that we see here, we think are common parts of psychopathology that might be viewed as culture-bound syndromes by people not from the United States.
Yeah. So growing up in Nigeria, for example, the thought of somebody developing clinical depression is thought of as, oh, this is like a white man's problem. It's not something that happens to us. And so actually, up until very recently, people would not go to seek help for depression, clinical depression in my country. And even till now, I've had talks. My talk show that I started, I've had people, you know, just come to you and tell you what exactly is this. Another thing is, especially like ADHD, for example, in my culture, like, they just think, oh, that's just an unruly child that needs to be treated. It's not something that needs to be treated. Why are you giving medication to this child? So these are some examples that I can think of right now. I'm sure there might be some other examples in other cultures, but that is a really good question.
Thank you, IJ. This is a great talk. I want to ask you, when you were studying about this, if you came across any studies. As we know, when people migrate, epigenetics may change with environment. So when we compare people with, say, American African versus African, or American Asian versus Asian, or American Indians versus Indians, did you come across any differences that have been studied, maybe in the pharmacology or how the metabolism is managed? I know the cultures change and they are mingling, but are there any studies that have studied these two populations?
So first is that when we become a part of another culture, our worldview also changes. And so the way we deal with emotions changes. So even though we grew up in a particular culture, when you migrate, it's almost like you start developing some part of your worldview starts resembling how the culture that you're in is. And so because of that, the way you handle emotions, the negative experiences starts to change over time. And then specifically for pharmacology, because I did not see any studies that compared like migrants versus people back in their home culture. However, that study about the HLA alleles did show that Asian Americans, they still had a higher frequency of the variation in the alleles, even though not up to those that were back in Asia. So hopefully we have more studies with ethnopsychopharmacology in the future that would help us have a clearer understanding of that.
All right, any questions from the virtual audience? If you have a question, please raise your hand and we'll get you to. Okay, Dr. Oliva, you can go ahead first.
Hey, IJ. First off, I want to, again, congratulate you on getting through residency, or adult residency at least, and wish you the best of luck in Atlanta. But question and comment. First off, I think your talk is very important because, especially on the console floor, we deal with this a lot. I think we might have seen this patient together too. A few months ago, I had a Hispanic patient, Spanish speaking. She came in because she had gastritis from drinking gasoline because she thought she had a stomach parasite. And she was on a suicide hold, and they consulted psychiatry because she drank gasoline. They thought because she was suicidal, but turned out in her culture, it's not unusual to drink a small amount of gasoline if someone thinks they have a stomach parasite. Granted, she drank too much and it was kind of dangerous. But these things do come up where culturally normal behaviors can be perceived as psychiatric illness. Like Dr. Casey said, though, the DSM is a Americocentric and Western-centric, statistical manual, diagnostic manual. Are there any more activities that you're aware of, or is the APA looking at involving more diverse or ethnically diverse people in making the DSM, or any more activities looking at or efforts looking at trying to widen the cultural understanding to non Eurocentric and Americocentric perspectives?
Yeah. Thank you very much for the comment and the congratulations. So when they were actually developing the cultural formulation interviews, they had not just Americans in that subgroup. And then they field tested the questionnaires in Kenya, India, the Netherlands, in Peru also, not just the US and Canada. And so they kind of tried when doing that to be somewhat inclusive. And looking at like the APA website when I was preparing for this, they are trying to make sure that especially when it comes to the cultural concept of distress, that they are including an international body when developing criteria leading to that. I hope that answers your question, sir.
It does. Thank you.
Dr. Pinnell, you're up next.
Can you hear me?
Yes.
Okay, this isn't a question. I just wanted to say, great job on your presentation. I think that you can offer a very unique perspective from your personal experience, and I just think that this is really important. I feel like a lot of times, when patients need to have any type of translation services and stuff, us as providers, we're kind of bogged down with, work, and we're like, oh, this is gonna take forever and stuff like that. But I think it's really important for us to take a step back and try to spend the time to really piece together the unique aspects of that patient and what they are trying to say. So I think that you did a really good job, and I'm proud of you.
Thank you, Megan.
Dr. Chopra, I think you have had your hand raised. Please ask your question.
Can you hear me?
Yes, sir, we can hear you.
This is a wonderful presentation, and the world is an ethnosphere. The different clans, tribes, nations. It's very colorful, and so that we learn from one another. It's all about adaptation. Now, now sticking to the topic, there's one condition called possession syndrome. It's region specific. Being in India, I've seen dozens of these cases. They're first considered to be this is culture-bound phenomena. There are some cases that are, trans-like states and dissociative states. So typically we send these patients. It's common mainly in Hong Kong, Singapore, Malaysia, India, Sri Lanka, Japan, and Haiti. They have a common link, the cultures have spread from Buddhism has spread from South India. People have gone into the Indonesia, Malaysia. And these cultures have been living together. So possession syndrome is, seen as more as a spirit possession. And typically shamans come and they, help them in dissociating the condition. And if they don't work out, then they go to the psychiatrist. So, involving a shaman is very important, involving the family. There's another condition which is not considered culture-bound anymore. That's Koro. These guys go to a frenzy and they go amok. It's called running amok. It typically happens in urban places where there's overcrowding and frustration. And it's like going postal, here. Suddenly a guy goes crazy, picks up a gun and starts shooting everybody here. So, it's a very vast topic, and there's a book called the Psychiatric Clinics of North America. It comes once a year. Every month I think there's a publication. It's on a particular topic, and there's one on culture-bound syndromes. I think it's still available at the library, I guess. Thanks again.
Thank you very much, Dr. Chopra. So I didn't delve deep into culture-bound syndrome because one of our fourth years, Dr. Tyler Rock, is going to be talking about culture-bound syndromes around the globe. So that's one of the reasons why I did not delve deep into that. And I kind of just focused the presentation on the variations in psychopathology in general. But thank you so much for your comments, sir.
Thank you, too.
Any other questions?
One of your slides referenced a psychiatrist named Frantz Fanon, who's not well known in the United States, but outside the United States, one of the most famous psychiatrists in history. Can you comment a little bit more about his contributions? He's perhaps more famous as a political philosopher than a psychiatrist, but really both.
A lot of, he was actually known as a post-colonialist word. He did a lot of work on what colonization, the psychological effects that it has on people. So he talked about mental illness not just being specific to just an individual, but essentially to all society. So he did a lot of work on the psychological impact of colonialism, slavery, and how that affects mental health as a whole. Like you said, yes, he was kind of very political, maybe could be somewhat like polarizing in his views, essentially. But he not only talked about the psychological effect of colonialism on the colonized person, he also talked about how it affects the colonizers also, and how, and how we can deal with this as a society.
For those of you who might be interested, there's a new biography published last year, kind of a political biography, very interesting history person.
Thank you, RJ. I think this presentation was one of the best grand rounds I've seen in my time in residency. I've learned a lot personally. And what you said about like trying to incorporate some of that in some of the patients that we see, I think our residents try to do a really good job of that, and they will do even a better job after learning from you today. There is obviously a huge immigrant population in Louisville. that we need to be more understanding of their culture, environment, and background. But also, I want to maybe make a small comment about the differences in American culture and even in different parts of Kentucky, some of the different cultural backgrounds of the patients that we treat. We just had a patient very recently on the inpatient unit where I'm working with Dr. Young and Dr. Nagbal and Dr. Huang. And Dr. Young's background yesterday differentiated between psychosis and the patient that was deemed ultimately as antisocial on discharge because of her understanding of scripture and the patient's background. So that I think is something that's very, very thoughtful, and we all need to be aware of in our approach to patient care. So thank you very much. And if nobody else has any questions, I think we'll end for today.
Thank you, everybody.
Thank you.